Hey everyone, imagine this. You're in the ICU, hooked up to all these machines, bright lights, alarms going off constantly. It's intense. Talk about a recipe for a nightmare, right?
Yeah.
And for many patients, that already stressful situation can lead to something even scarier. Delirium.
Yeah, it's not exactly a recipe for a relaxing spa day.
Not at all. So today we're going deep into the world of intensive care, specifically those big challenges: pain, agitation, and delirium.
These issues are so intertwined and they can have a big impact on how well and how quickly a patient recovers.
It's fascinating stuff, and you definitely don't have to be a doctor to appreciate this deep dive. We're going for those aha moments, those bits of knowledge that make you see critical care a bit differently. So let's unpack this trifecta of challenges. And we'll start with pain. I think we've all felt pain at some point, but try to imagine dealing with it when you can't even communicate what you're feeling because you're on a ventilator.
That's what makes managing pain in the ICU so complex. It's not as simple as saying, oh, you're in pain, let's give you some morphine, because clinicians have to consider so many factors. The type of pain, how the patient's body handles medications, what other health conditions they might have.
So it's a real balancing act. You want to relieve pain, obviously, but not cause more problems with over-sedation.
Exactly. And that's where the whole idea of analgesia-based sedation comes in. It means making pain relief the top priority, instead of just relying on a bunch of sedatives to mask the problem.
So it's about treating that pain first and foremost, then adjusting sedation levels as needed. What sort of medications are commonly used? I know opioids are used pretty often in the ICU.
They are. What's interesting is the variety of opioids used, they actually all have different effects. You've got morphine, fentanyl, alfentanil, sufentanil, and remifentanil, each with their own, let's say, quirks.
Now, this might come as a surprise, but even though these opioids target the same receptors in the brain, the way each one is metabolized by the body makes a huge difference.
Huge. It basically means doctors can fine-tune pain management by using medications that act quickly or last longer, depending on what they're trying to achieve.
So give us an example.
Take fentanyl. It's incredibly potent, much stronger than morphine, so we often use it for severe pain, or in situations where you need a fast-acting medication. Remifentanil, on the other hand, it has an extremely short duration of action, which makes it useful for procedures. But you need a solid plan for managing the pain once it wears off.
It's almost like choosing the right tool from a toolbox. Each one is designed for a specific purpose. But what about non-opioid options? Things like paracetamol, which is something many people will have in their medicine cabinet at home.
Paracetamol, or acetaminophen, definitely has a role to play in the ICU. I think of it as a good sidekick to opioids, and it's often given alongside them to boost pain relief, hopefully allowing us to reduce the required opioid dose, which can mean fewer side effects.
Now, you hear a lot about NSAIDs, like ibuprofen, for pain relief. Are those used much in the ICU?
They're used a lot more cautiously in the ICU. See, while they can be effective for pain, the research is showing us that NSAIDs have a higher risk of causing problems in critically ill patients, things like kidney problems or even bleeding.
So those potential risks often outweigh the benefits.
Yeah, pretty much. The guidelines do suggest that NSAIDs might be helpful after certain surgeries, like cardiac surgery, but even then we use them very carefully and monitor the patient closely.
Makes sense. So we've covered the big ones: opioids, over-the-counter pain relievers. The research mentions a couple of other medications I found interesting: ketamine and clonidine. What's their story?
There's a lot of interest in these medications and how well they might relieve pain in the ICU. Ketamine, now that one's traditionally used as an anesthetic, but it also has pain-relieving properties. What's really cool is that it works so differently to opioids. It targets a completely different pain pathways.
So it's another potential weapon in your arsenal to fight pain, particularly for those patients who don't respond well to those more traditional pain relievers. But it sounds like we need more research.
We do, and this actually highlights a really important trend in critical care, and that's multimodal analgesia. Basically, it's about using different types of pain medications together to try and target all those different aspects of a patient's pain.
So attack the pain from all angles, so to speak.
Exactly. So instead of relying on a high dose of just one medication, we can use a combination at lower doses, which can mean better pain control and hopefully fewer side effects for the patient.
So it's all about minimizing risks and maximizing benefits.
Absolutely.
Now, speaking of minimizing risk, let's talk about agitation and sedation in the ICU. It seems like kind of a necessary evil, right? You need to keep patients comfortable and often sedated, especially if they're on a ventilator. But like you said, there are always risks.
You've hit the nail on the head. It really is a balancing act. Sedation can be really important. It helps patients get through those life-saving treatments. But keeping them heavily sedated for long periods, that can cause a whole other set of problems.
And that brings us to the necessary evil part of the equation.
Yeah, it's a real balancing act, that's for sure. Trying to find that sweet spot between making sure the patient is comfortable, but also minimizing those downsides of sedation. And these sources make it crystal clear. Keeping someone in that deep sedation for too long, well, it's linked to a whole bunch of complications.
And we're talking some serious stuff. Longer time on the ventilator, higher risk of infections, muscle weakness from not being able to move around, even higher risk of dying.
Exactly, and it's precisely why the whole approach to sedation in the ICU has shifted, and quite dramatically. We've moved away from that keep 'em sedated mindset and towards a more proactive approach, prioritizing lighter sedation as much as possible.
So finding that minimum amount of sedation to keep the patient comfortable and safe, but not so much that it actually slows down their recovery.
You got it. Ideally, we want our patients to be awake and interactive whenever possible. Why? Well, for one, it helps us monitor how they're doing neurologically. It lets us get them moving and into physical therapy sooner. And importantly, it actually improves communication with us, the care team.
It makes you appreciate how vital those assessments of agitation are. The sources talk about scales like the RASS, the Richmond Agitation Sedation Scale. It's a bit of a mouthful.
It is a bit of a mouthful, but it's an essential tool, believe me. Imagine a volume knob, for sedation. That's kind of what the RASS. It gives clinicians this really precise way to figure out how sedated or agitated a patient is, which helps them adjust medications and avoid those extremes: too much sedation or not enough.
So no more guesswork when it comes to gauging those sedation levels. I also noticed that the research mentions these things called sedation breaks and sedation protocols. What are those all about?
Both of those strategies are aimed at, you guessed it, minimizing sedation. Think of a sedation break like hitting the pause button on sedation for a little while.
Okay, so a scheduled timeout from the medication.
Exactly. It lets the patient wake up a bit, giving doctors a chance to accurately assess their neurological status, see how they're breathing on their own, and figure out if they actually still need to be sedated.
So it's a chance to step back, reassess, and maybe tweak the sedation plan based on what the patient needs at that particular time.
You got it. And the research shows that these sedation breaks, they can have some pretty amazing benefits. They can lead to shorter times on the ventilator, shorter stays in the ICU, even fewer CT scans to figure out why a patient's consciousness might be changing.
Okay, so those are some positive outcomes. How about sedation protocols? How do those work?
Those are super helpful. They're like guidelines or algorithms that help us figure out the best sedative medications to use and at what dose based on a patient's specific needs and how sedated we're aiming to keep them. They take a lot of the guesswork out of it and help make sure everyone's getting consistent care.
So it's like having a roadmap for sedation, making sure patients are getting the right amount of medication at the right time with regular checkups along the way.
That's a great way to put it. And the research is there to support using them. Studies show that standardized protocols can really lead to better outcomes for patients in the ICU.
So we've talked a lot about trying to minimize sedation as much as possible. Are there ever times in the ICU when deeper sedation is unavoidable?
Oh, absolutely. Think about procedures, like when we need to intubate a patient, putting in a breathing tube. Those situations require the patient to be totally still and relaxed for their own safety.
Right. Or even in cases of a severe brain injury, when minimizing brain activity is crucial to try and prevent more damage.
Exactly. Or even end-of-life care. Sometimes sedation can provide comfort and relieve suffering. The key is using sedation thoughtfully as a tool when it's truly necessary, but also always understanding those risks and benefits.
Okay, so sedation is clearly a valuable tool, but it can also be risky if not used carefully. Now, let's get into the nitty-gritty of those sedative medications used in the ICU, because it seems like they don't all work in the same way. For instance, I know propofol is widely used, but I've also heard about something called propofol infusion syndrome. That sounds a little scary.
Yeah, propofol infusion syndrome, or PRIS for short, is definitely something we're always aware of when we use propofol. It's rare, thankfully, but it can be very serious.
The research papers describe it as this, cascade of problems that can impact lots of different organs, like the heart, kidneys, and muscles.
That's right, and it can be life-threatening. We're
Right.
still trying to understand exactly what causes PRIS, but it seems to be linked to a disruption of how the cells produce energy. Those little powerhouses of the cells, the mitochondria, imagine a city-wide power outage, but on a cellular level, that's kind of what happens.
So what signs do you watch out for? What are the red flags?
There are a few key things we keep an eye on. Using propofol for too long, especially at high doses, if a patient has a pre-existing condition like a severe head injury or sepsis, even things like metabolic disturbances can increase the risk.
It makes you realize how important monitoring is in the ICU. Not just checking those vital signs, but really scrutinizing lab results and watching for any tiny change that could signal trouble.
Early detection is key with PRUS. If we even suspect it, the first thing we do is stop the propofol immediately and provide supportive care to try and manage any symptoms.
Okay, so moving on from propofol, what about those alpha-2 agonists? Drugs like dexmedetomidine and clonidine. It seems like they're becoming more common in the ICU. What makes them different?
They work in a really interesting way. They go after these alpha-2 receptors in the brain that are involved in things like sedation, how we perceive pain, and even blood pressure.
And one of the benefits is that they don't suppress breathing as much as other sedatives. I read that they're often preferred for getting patients off the ventilator.
Exactly. They provide a more gentle sedation, allowing patients to be more awake and cooperative, but still helping to manage their pain and anxiety.
It's not all positive, though, is it? The research also mentions some potential downsides, things like a slow heart rate bradycardia and low blood pressure.
You're right. Those are definitely things we have to consider, particularly in patients who are already quite sick. So we're very careful about monitoring, especially when we first start the medication. We're checking heart rate, blood pressure, the whole 9 yards.
It seems like every medication comes with its own unique set of benefits and risks. Now, what about those old standby sedatives, the benzodiazepines? Things like midazolam, lorazepam, those have been around for a long time.
They have, that's for sure. And while they're still incredibly useful in certain situations, we don't tend to use them as much for sedation in the ICU these days.
Why is that? Are there concerns about safety in the ICU?
It's not so much immediate safety concerns. It's more about what the research is telling us about their potential long-term effects. You see, studies have shown a link between benzodiazepines and a higher risk of delirium.
Delirium, that brain fog we talked about earlier.
Yeah.
Definitely not something you want to increase the risk of, especially given those potential long-term cognitive impacts.
Exactly. Now, there are situations where benzodiazepines are really important, managing alcohol withdrawal or seizures, for instance. But these days, the general trend is to use them more cautiously, especially for sedation.
It just goes to show how medical practice is constantly evolving as we gather more information about the long-term impact of those interventions. So the research mentions a couple of other sedatives, ones that aren't used quite as often, ketamine and thiopental. What are those all about?
Ketamine, we talked about that one earlier for pain, but it can actually be used for sedation as well. It's interesting because it works in a completely different way to most sedatives.
How so?
Well, it causes this dissociative state, almost like a disconnect between the mind and body. It's not just about inducing sleepiness. It's definitely useful sometimes, but not our first choice for a routine sedation in the ICU.
And thiopental.
That one's a barbiturate. It's a pretty old class of medication, actually, and we mainly use it for short-term sedation. Like when we're putting someone under for surgery, we only use it occasionally in the ICU.
For any specific situations?
Yeah, things like refractory status epilepticus, basically. Prolonged seizures that are really tough to get under control. That's one scenario.
Not something you see every day.
Right. We might also use it for really high intracranial pressure in certain cases, but again, very specialized situations.
So we've covered a whole range of sedative medications, each with their own special characteristics and uses. Now, what about medications that aren't typically considered sedatives, but are sometimes used to manage agitation in the ICU? Things like haloperidol. Now, that's actually an antipsychotic, so how does that work in this context?
That's a great question. You're right. Haloperidol is usually used for psychosis, and in the ICU, we often use it for acute agitation, especially if we think it might be related to delirium.
So it's not about sedation, but more about calming down a patient who's agitated, confused, and potentially a danger to themselves or others.
Right. However, the research suggests that while it might help manage those immediate acute symptoms, it doesn't really address what's causing the delirium in the first place.
And there's not a whole lot of evidence to show that it helps prevent delirium from developing either, right?
Exactly. And that brings us right back to the importance of those non-pharmacological strategies, early mobilization, making sure the environment is calm, minimizing sleep disruptions, those types of things.
It's about creating that healing environment for the patient.
Absolutely. But to really understand delirium, we need to dig a little deeper. It's often called the silent epidemic for a reason. Its effects, well, they can be really significant and last a long time.
Let's unpack that. Delirium seems to be this, I don't know, elephant in the room in a lot of these research papers. So paint us a picture. What exactly is delirium? How common is it in the ICU? And why should we care so much?
It's interesting, delirium, it's often misunderstood. People hear that word delirium and they picture someone who's really agitated, but it's actually this whole spectrum of mental disturbances. And you're right, it's a huge deal in the ICU.
Hmm.
These papers really highlight how common it is, how serious it is, especially for our sickest patients. I mean, we're talking up to 80% of patients on ventilators experiencing at least some degree of delirium.
80%? Wow, that's a staggering number.
Yeah.
So almost a given then that if you're seriously ill in the ICU, you might experience this. No wonder they call it an epidemic.
It really is. And it's not like it just vanishes overnight. Delirium, it's linked to all these negative consequences, things like an increased risk of dying, longer hospital stays, higher healthcare costs. And then there's the potential for long-term cognitive issues. Imagine going through a critical illness, fighting to recover physically, and then having to deal with things like brain fog, confusion, memory problems, even after you leave the hospital.
It's a lot, and it really underscores that when it comes to critical illness, our brains are just as vulnerable as our bodies.
Yeah.
So in this silent epidemic, who's most at risk? What are those risk factors for delirium in the ICU?
Well, research points to a few key things. Some are what we call predisposing factors, things a patient might already have when they're admitted to the ICU that increase their risk. Things like older age, if they already have dementia, history of high blood pressure, even previous episodes of delirium, those all play a role.
So it's like those pre-existing conditions make the brain more vulnerable even before someone enters the ICU.
Precisely. Then you've got what we call precipitating factors, things that happen within the ICU environment that can actually trigger an episode of delirium. And this is where those constant lights, the noise, those frequent interruptions, they all come into play. Sleep deprivation is a big one, or a really big one.
Yeah, it's not like the ICU is known for being particularly restful and calming, is it?
No, definitely not a spa day. And that constant sensory overload, having your sleep-wake cycle disrupted, it can really mess with the brain. Add to that the stress of being critically ill, pain, discomfort, and certain medications like benzodiazepines, and, well, you've got this perfect storm for delirium.
It really drives home how important those non-pharmacological interventions are, things like dimming the lights, keeping noise to a minimum, trying to maintain some semblance of a regular sleep-wake cycle, almost like you're trying to create a sanctuary for the brain in the middle of all that chaos. Now, once a patient is in the ICU, how do you actually detect delirium? The papers mention these standardized screening tools, the CAM, ICU, and the ICD-SC. What can you tell us about those?
Oh, those are essential. They're like specialized checklists that help us assess a patient's mental state. And the great thing is they're designed specifically for the ICU, so they take into account that a patient might be on a ventilator or unable to speak.
So even if a patient can't communicate what they're experiencing, you can still get a good sense of what's going on.
Exactly. And remember how we said delirium can fluctuate? It's not always constant, so we use these tools to do frequent assessments by the bedside just to make sure we're catching any changes early on.
Okay, so let's say you've identified that a patient has delirium. What happens then? How do you manage it, hopefully reverse it?
Treating delirium is interesting. It's a bit like detective work. You have to figure out what's causing it in the first place and address that. That might mean treating an infection, stopping or changing a medication that could be contributing, making sure they're getting enough fluids and nutrition, managing their pain. It's really a team effort.
So you're not just treating the delirium in isolation. It's about looking at the whole picture, everything that could be playing a role.
Exactly. And while we might use medications to manage specific symptoms like agitation, we really try to focus on those non-pharmacological interventions.
Right, those things we talked about before, like early mobilization, getting that patient up and moving as soon as it's safe to do so, minimizing those disruptions, reorienting them to their surroundings, encouraging family to visit. Sounds like creating that healing environment is paramount.
It really is. It's about restoring some normalcy, some routine, even in the ICU. And these simple interventions can make a huge difference.
We talked earlier about haloperidol being used sometimes for agitation in the ICU. What's the evidence say about using it specifically for delirium?
That's a good question. And actually, those guidelines we keep mentioning are pretty clear on this one. They don't recommend haloperidol for treating delirium.
They don't. Why not?
The research just doesn't support it. We have to remember that every medication comes with potential side effects, so we always have to weigh those against the potential benefits. And when it comes to haloperidol for delirium, the evidence for its effectiveness just isn't there.
That's really good to know. And it highlights how important it is to constantly reevaluate what we're doing and make sure it lines up with the latest research. Are there other medications being investigated that might be more promising in treating delirium?
There are. Dexmedetomidine, that alpha-2 agonist we talked about earlier, well, some studies suggest it might not only help manage delirium, but it might even help prevent it.
So not just treating the symptoms, but actually preventing it from happening in the first place. That's incredible.
It's really exciting, but, and I do want to add this, the research is still in the early stages. We need more larger studies to be sure before we can say definitively that it's the answer.
It's still a beacon of hope.
Mm.
What other avenues are researchers exploring?
Lots. People are looking into things like optimizing nutrition, the potential benefits of supplements like melatonin, even music therapy and aromatherapy again, trying to create that calm, healing space.
It really speaks to this idea that treating delirium, and even better, preventing it, requires a multi-pronged approach. You have to think about every aspect of a patient's well-being, not just their physical health.
Exactly. And that brings us to a really important point as we wrap up this deep dive into pain, agitation, and delirium in the ICU. These are what we call acute conditions, meaning they primarily occur during the critical illness, but their effects, those can linger long after a patient leaves the hospital.
And the research is pretty clear. Those potential long-term consequences of delirium are significant, particularly when it comes to things like cognitive function. It's like this ripple effect. Delirium in the ICU can increase the risk of having problems with thinking, memory, and concentration, even months or years down the line.
Yes. And it just goes to show how urgently we need more research in this area. We need to find effective ways to not only manage delirium in the ICU, but to actually protect patients from those long-term cognitive risks.
It's about protecting their minds as well as their bodies, making sure they can return to their lives with all cylinders firing. It's an incredibly complex and evolving field, and I think this deep dive has given everyone a much better understanding of just how interconnected these challenges are in the ICU. But it also leaves us with a crucial question. How can we, as healthcare providers, continue to evolve critical care to do a better job of addressing those long-term cognitive needs? That's something I'd encourage everyone to think about as they continue to learn and explore this amazing and often surprising world of critical care.